So today's session, Mental Health Matters in Early Childhood, is an overview of the foundations of mental health in children 0 to 5 and will cover the signs and symptoms of mental health concerns in infants, toddlers, and preschool-age children, and so much more. Now, this course, for those of you that are here live, this course meets the qualifications for 1.5 hours of continuing education credit for LMFTs, LCSWs, LPCCs, and or LEPs as required by the California Board of Behavioral Sciences. So we will talk about that for you. And it looks like some people might have dropped in a little bit late. We'll make sure to drop those note-taking slides for you in the chat again. All right, now, without any further ado, let me introduce today's presenters to you. I first want to introduce Yanin Guo, who is a licensed clinical psychologist at Rady Children's Hospital Developmental Evaluation Clinic, where she provides comprehensive evaluations for children 0 to 5 years with developmental, mental health, medical, and family needs. She also provides developmental evaluations for Rady's Kid Start program, a program for children ages 0 to 5 with complex developmental and mental health needs. Yanin is also a board-certified behavior analyst. She specialized in working with individuals with autism spectrum disorder before starting her doctorate program, providing behavioral services and parenting training. Yanin received her doctorate degree in applied clinical psychology from the Chicago School of Professional Psychology, San Diego. I'd also like to introduce Megan Lukasic, who has been a licensed clinical psychologist since 1998 and has worked at Rady Children's Hospital since 1999. Megan specializes in the assessment of infants and young children. She has extensive experience in diagnostic assessment of neurodevelopmental disorders and early mental health concerns, including childhood trauma. In addition to providing direct clinical service, Megan manages the hospital's developmental evaluation clinic and is the co-training director for the clinic's APIC-approved postdoctoral fellowship program. She is a former clinical director of Rady Children's Kid Start program, a program for children ages 0 to 5 with complex developmental and mental health needs. And with that, we want to welcome both of our presenters, say thank you so much for being here this afternoon, and we can't wait for the conversation.
Thanks for having us.
All right. Well, thank you, Jessica, for the very warm introduction, and we're very happy to be back for this presentation. This is definitely something that Megan and I feel very passionate about, and we're very happy and really honored to be here to be able to share what we've learned, just by working with our families and our kiddos with all of you on this webinar today. First thing first, we would like to just briefly introduce our agenda for today's presentation. So first, we're spending some time talking about why mental health matter in early childhood. And then this is definitely something that we'll be talking throughout this entire webinar. And then we'll be looking at some early signs and symptoms for, mental health concerns or issues in the population that we work with, specifically kids, from 0 to 5. And then we'll take a brief look at the history of mental health assessment and then some of the revisions that kind of came along the way and then how those revisions came about. And then after that, we'll spend some time specifically looking at the impact of trauma, talking about some of the different types of trauma and then how, again, we've come to learn how they impact the children and the families that we work with. Just by working with this population, there are some really commonly seen developmental disorders. So we'll be spending some time looking at some of the symptoms and characteristics of those developmental disorders, specifically autism spectrum disorder, ADHD, as well as fetal alcohol spectrum disorder, and depression and anxiety. And then at the end, we'll end on a positive note and talking about some of the resiliency that we see in the children and family that we work with, as well as talking about how to identify protective factors, for these families so that we can continue to provide those support for them. All right, so before we get started, or first thing first, we would like you to meet Jimmy. So Jimmy is 26 years old, and then at the age of 26, he is currently incarcerated. He has very limited social or positive support, has no family or friends, and there's a history of violence if we look at his chart, as well as a long history of substance use. So as clinicians, for our initial intake or our consultation session, it's not really just an opportunity for us to learn about, the current concerns, but it's also an opportunity for us to really learn about the family history. It really gives us the opportunity to look at the child within the context of the family, or really within the environment that they're in currently, or in the past. So let's take a look back. Let's take a look at Jimmy when he was 10-month old. So when Jimmy was 10-month old, he was removed his parents' care at birth. And at 10-month old, he was already in his third resource home placement. And then before he was removed, there was a family history of domestic violence. And then he was born prenatally exposed to different substances as well, specifically alcohol. So taking a look at Jimmy at 10-month old, he had a lot of risk factors that we know now really impact a child's early development, whether it's their cognitive, their attachment with the environment, their ability to really, show that early compassion for other people in their social environment. So now the question is, if we had known Jimmy when he was that young, when he was 10-month old, if Jimmy had came to your clinic or the work that you do, when he was 10-month old, what could we do? And if you're currently working with someone like Jimmy, who's a younger one, but has gone through a lot of really aversive experiences in their life, what are some of the things that you will do with them? So not just that, but what could we do over time to really better support his needs, to make sure that he is getting the support that he needs along the way as he matures, as he transitions to different environment. And really the message that we want to emphasize here is that it's never too late, but it's also never too early. The time is now, and then we really need to start providing support for these little ones now. And we want to just share some kind of statistics on the adult and adolescents' mental health by the numbers. So 1 in 5, every 5 U.S. adults experience mental illness each day. These include, each year. So these include diagnosed and undiagnosed. So for someone that haven't really had the opportunity to really go out and seek professional help, they're included in this statistics too. 1 in 20 US adults experience serious mental illness each year. So when we talk about serious mental illness, so these might be, those people that require hospitalization, or they require more consistent management with their medication, or really they're in, require more mental health services. And then 1 in 6 US youth aged between 6 to 17 experience a mental health disorder each year. And half or 50% of all lifetime mental illness begins by age 14. So again, we're seeing kind of some of those early, symptoms and behaviors by the age 14, and then 75% by the age of 24. And suicide is the second leading cause of death among people aged between 10 and 34 years old. And now looking at some of the numbers for early childhood mental health. So ADHD, behavior problems, anxiety, and depression are the most commonly diagnosed mental health disorders in children between the age of 3 and 17. So if you think about the kiddos that you work with, if they kind of fit within that age range, what are some of the diagnoses that brought them into your work? So think about, do they actually have any of these 4 that we were just mentioned that are mostly commonly diagnosed with this age group? So 98% of children have received an ADHD diagnosis, and 94% of children have diagnosed anxiety. And then as, if you guys have been kind of keeping up with the research, or just really from all these different webinars, we know that the depression and anxiety rates have increased very significantly over time, specifically with this age population. And 80.9% of children have a diagnosed behavior problem, and 4.4% of children have diagnosed depression. And also, 1 in 6 in the United States, 1 in 6 children aged between 2 and 8 years old had a diagnosed mental or behavioral or developmental disorder. So again, very alarming statistics.
All right. So I have a brother-in-law, and he is really bright. He's a really bright guy. And I was talking to him one day about the work that I do. And I was telling him how I work with mental health and children under the age of 6. And he was just, really baffled by this. And he was like, how can you possibly identify a mental health problem in somebody that young who can't talk, and who's barely walking, and just new to this world? How do we do that? And so I said to him, well, think about the 3 things that really little ones do the most and do the best. They eat, they sleep, and they poop. And we can look at those 3 things, those very common activities, and say, if something's not going right in any one of those areas, we need to pay attention to that. So if a child is overeating, a very young baby is overeating or undereating, that's a concern. A child who sleeps too much or too little, another concern. And same with constipation and diarrhea. That is the body's way of saying, something's not going right. And of course, our obligation is always to first look at a medical concern. But if we've ruled that out, we need to look further at social, emotional, and other issues that may be going on. So it's very easy for us to have these really little ones, even before they have words, to tell us, pay attention, something's not right. I want to do a quick kind of historical look at kind of how we came to diagnose the way that we do currently, and maybe even a glimpse into where we're headed. If we look back into kind of the late 1800s, that's when we first started really coming up with ways of classifying different disorders. And we did that from a medical lens with the ICD classification system. And again, that really was looking at medical diagnoses and different disorders. And that went on for a while, different revisions over time. But one of the things that we came to realize was that as we were looking at the medical issues, we were really missing a lot of things that were going on for people, namely mental health concerns, social emotional issues. And so in 1952, the Diagnostic and Statistical Manual was born, the first edition. And then every 10 years or so, a bunch of really smart people would get together and decide, you know what, we need to do better. We need to kind of reclassify things. We need to take a look at our current classification system and make some revisions. And so we've seen different revisions to our DSM over the years. And we're currently on the DSM 5TR, the text revision that came out in 2022. But even with that kind of improvement in the way that we looked at individuals when things weren't going well, and when we attempted to create intervention that was going to help them, we identified the fact that talking about mental health issues in adults for sure didn't always kind of translate to younger children. And I think the DSM has done a better job over time of capturing school-age children and adolescents, but the really younger children, that was still a missing area. And so in the 1990s, we had the diagnostic classification system called the DC 0 to 3 that came to us. And that was really looking at, well, how can we talk about children in a unifying way, really little kids, in ways that will help direct services and really do a better job than our current DSM classification system is in describing what's going on. And so we had the the DC classification system. That existed for a while. There was one revision there in 2005. And then in 2017, we decided we didn't decide, but folks decided to expand that to the diagnostic classification system for birth to 5. And so that's the current system that we have and that we can use and rely on to more accurately create a description of a very young infant or child before they turn 6. Next slide. So while we've made a lot of advancements and a lot of improvements, there's still room for improvement. And as I see the different backgrounds of folks that are here today, I'm hopeful that some of you will really help join us in creating, informing policymakers to do a better job of actually funding the diagnostic classification for younger children, because that still is a challenge in many states across our nation. And so what we do is we often will use what we call a crosswalk system to say, okay, I can get funding through my ICD-10 classification system or my DSM, but I can't using my DC 0 to 5, but I still can use the language in that classification system to talk about the child. And then, in terms of billing, crosswalk it to the the DSM or the ICD classification system. So you can see here as one example, one of the diagnoses that we might talk about for a very young child is sleep onset disorder. And in the DSM, that would crosswalk to insomnia disorder, or the ICD-10, it would be the non-organic insomnia. And then that would have a corresponding code. So that is one way that we are kind of currently using our systems to help communicate, but also I think just a recognition that over time we're seeing how there is room for improvement in our systems, and that we really need to make sure that when we're talking about children, we're doing it at a level that is fitting with where they are developmentally and an understanding of just the expectations for that age group. It's really, you can't put expectations about mental wellness looking at adult classification on a child, and conversely, a school-age child is going to present very differently than a younger child. And so having these different classification systems, I think, really does a much better job of helping us to talk as professionals, and then to talk to our families about what's going on in ways that are meaningful and relatable and more accurate too.
And I just want to add to that. I think, as a clinician, sometimes when you see the code, we're not trying to categorize the kids that we see, but I think sometimes when a kid has gone through so many changes, a lot of their needs from a clinical perspective gets lost within all those transitions. So having these codes in the system, or having these information in there, sometimes it helps them connect to it helps to connect them to the services that they really need, because I've had so many times where I'm having my initial consultation with a resource caregiver who's only had the child for 2 months, and then they don't really have a lot of these knowledge about the kids they're currently with. So sometimes it just makes it really harder to get that thorough history. So sometimes by having these information in the system, it definitely helps us clinician to kind of guide our treatment plan as well.
That's a super good point, Yana. And I think, one thing I often will talk with families about is people aren't diagnoses. The child who we're talking about a specific diagnosis for is the same person that came into the office before they had that diagnosis. It's just now, hopefully, we have some unifying language that will help us to communicate their needs and help open the doors that will give them more opportunities for a more positive kind of future. As we think about Jimmy, the guy in the first slide there, if only somebody had been talking about his needs early on, maybe his trajectory would have been quite different than it was as an adult. And we don't have to wait until somebody is incarcerated and really having a hard time to be able to intervene. And so using the label, if you will, while it doesn't capture the whole person, can really help make a big difference. And so that is part of why we diagnose and use these different tools that hopefully help us do a better job of communicating things to families and to other providers. Okay, so whenever a child comes in to my office and is presenting with developmental concerns or behavioral concerns, the first thing I'm going to do is I'm going to get a thorough history, as Yana talked about, and as much information as we can get, the better, right? We want to know about pregnancy. We want to know about hearing and vision. We really want to know about any kind of medical issues that are going on, because that certainly can explain why a child may be presenting a certain way. Another thing that's at the top of my list that I'm always going to be with every single child, no matter what the presenting concern is, that I'm always going to bring up is there any history of trauma? So I'm asking that question and including that thorough assessment in my mind always includes that. And I want to ask the group, if you guys don't mind, unmuting yourself and just kind of shouting out if you can think of an example of what might be a trauma. Just anything that comes to mind.
And then if you don't have the option of unmuting yourself, you're more than welcome to type that in the chat
Yes.
for us to see as well. Someone said sexual abuse.
Oh yeah, thank you. It says they can't unmute. Good.
Mm-hmm.
Neglect, divorce, domestic violence, bullying, a dog bite, screaming, witnessing domestic violence, exposure to drugs, medical trauma, chronic illness, loud music, hearing fighting constantly, loss of a caregiver, being removed from their home, homelessness, poverty, food insecurity, neglect, death in a family, parent divorce, all of the above. Yes, those are great examples. And I think, and verbal abuse, thank you guys. You came up with some really, I think, good ones. Car accident, a parent incarcerated. So some of these are instances that happen to the person directly. And like some said, you know, some are maybe a witness to things, hearing things, more indirect exposure. Another good one that I saw several times, and I'm so glad that people are bringing this up, is neglect. So sometimes it's the absence of that caregiving that we should expect as a young child that can be significantly detrimental. So those are great examples. Deployment, good ones, yes. And we're going to talk more about just, again, the ways that I think some of the tools that we have at our disposal are doing a better job of helping us to get to all of these different forms of trauma that could be impacting the person that we're working with. There are different types of trauma. So we have acute trauma, and that could be a one-time event, like someone said, a car accident. Sometimes it's chronic trauma, so maybe exposure to domestic violence over time or exposure to neglect over time. And then there's complex trauma, which can be defined different ways, but the way that I think makes the most sense and that I hear a lot is when you have a trauma that's inflicted on somebody by somebody that is significant to that person. So a relative, somebody really important to them. Those are complex traumas. Next slide. Okay, so now we're all sitting, I wish we were in a room together, but I think for many of us, I know myself, as I look up, I can see what looks like you hopefully, or looks like what's on this slide here, and maybe you see it in your site too there, but it's supposed to be a tile, a ceiling tile. And what I want you to envision is that you're sitting there in your office or wherever you're viewing this, and that tile on your ceiling, a piece of it comes down and falls. And for some of us, when that happens, that event happens, that's going to be not a big deal. You know, we'll just be like, oh, got my desk a little dirty, I'm just going to push it aside and go on with this presentation. Some others of you, that happens, and maybe you're trying to pay attention to all the amazing things that Yanin and I are saying, but maybe you're just kind of bothered by it. It's just sort of staying with you, and throughout the whole presentation, you're distracted by that. And then others, maybe, you know, that's a real trigger for you, and you just can't even continue to participate in this presentation. It's going to bother you later on in the day as you go home tonight. It's a real significant thing. And that's, I think, a very important, someone said water damage last year. Oh, there you go. Yes. So that sometimes these things lead to other things to notice. But going back to, you know, the idea of this trauma, you know, or this event, excuse me, it really can vary from one person to another. So what might be significant for one person is really not that significant for another. And I think, you know, as professionals, our duty is really to get to know our individual, you know, child and family, and to understand their perception of the event, to really understand the impact, and to not really think about, you know, our impression of an event and to assign a level of significance for that event, but to really take the time to listen and to see how they're perceiving things. The other thing I think that's super important is not just their perception, but maybe their temperament. So, the child, like, do they have an easygoing temperament? Maybe it's so easygoing that they haven't really taken the time to process what's happened. And so they keep pushing it aside. Maybe it's a situation where their caregiver also, their perception is really impacting the child significantly. Maybe it's a caregiver who themselves has what we call ghosts in the nursery. They have, significant trauma that they've brought to their own parenting relationship, and that's impacted their perception of a trauma. So the child may say, well, that wasn't a big deal, but to the caregiver, it was a significant thing. And so then that's impacting that relationship, and then hence impacting the child. And, whether the parent is, able to be protective of the child. It could be related to their own history or their own kind of interaction with that event. So it's really important that we think about trauma as multidimensional and as having an impact that can vary from person to person. Next slide. Okay. So this is a picture of Nadine Burke-Harris, Dr. Nadine Burke-Harris. And if you guys are into TED Talks and you have 20 minutes, this is a really good use of your time. She was our first Surgeon General of California and really made it her mission to raise awareness of adverse childhood experiences, of childhood trauma and its impact, and to bring to the table a conversation about trauma, including in our medical practices, our behavioral health practices. So one of her goals back in 2017 was to reduce the rate of toxic stress by half. And how she did that was she and the Department of Healthcare Services, DHCS, and the Office of the California Surgeon General, which was her office at the time, they launched this initiative where they actually paid providers to bring up the conversation about toxic stress and trauma into a medical setting, into a doctor's appointment, asking the question of, have you experienced this event? Have you experienced an event that was traumatic or that is typically perceived as traumatic? And then including that as part of the understanding of the child. This is really important because one of the things that we've learned is that adverse childhood experiences are highly correlated with future kind of negative outcomes, even early death and other significant medical issues, socioeconomic issues, mental health challenges. We know that out of 10 questions that are asked about things that are typically perceived as traumatic, whether it's physical abuse, neglect, emotional abuse, and other events, we can look at that and say, if these events happen and you get a score of 4 or more out of 10, this is known to be highly correlated with these negative outcomes. And that's something that actually was first discovered here in San Diego at Kaiser Permanente. And for those of you familiar with Kaiser, you know that that's a medical facility that serves primarily middle to upper class. And what they found and kind of stumbled upon this, Dr. Vincent Felitti, an internist, kind of stumbled upon this connection to adverse childhood experiences and other poor medical outcomes. In his case, it was looking at it was looking at obesity. He was trying to help people who were overweight and stumbled upon the fact that a commonality with people who were overweight was these higher adverse childhood experiences, these higher ACE scores. And so this led to this real movement. And I'm sure most of you have heard of the ACE survey. And Dr. Nadine Burke-Harris has taken that survey and expanded it to the medical field, to saying, we want you guys to be bringing this up with your patients, and we're actually going to pay you for it. So they pay providers to give these surveys. They've also added more events than just the typical, the kind of initial ACE survey used. They have added some other toxic stressors, and I think some people brought those up in the chat there with some examples. So things like discrimination, homelessness, foster care, removal from the home. Those other events have also been recognized and again are brought into the conversation so that we really can be treating the whole person. This initiative has really taken hold in California. I'd love to hear from other states that are represented here if you're also seeing it in your state yet, because I think it's a really wonderful tool that helps us do a better job of accurately understanding what's going on with a child. And we're going to talk more about different behavioral presentations and how they can all overlap. But if we're not talking about these issues of toxic stress, these events that have happened, if we're not bringing that up, we may be very, we're at risk for really missing the boat here and really directing family along a wrong path, a misdiagnosis. So, see, anything else I want to say about that? I think the only other thing that just to mention really quick before we go to the next slide is that this has continued, and in fact now, so it started at the Surgeon General's office, is now kind of switched hands in UCLA and UCSF, the University of California. They've taken this initiative, and so it's continuing to grow and garner support across our state, and I hope across our country as well. Now, next slide. Thank you. So, you know, as I was saying, the reason that we need to pay attention to this, there's so many reasons, right? It's really doing good work, but it's also about the fact that we can actually impact our society in terms of medical costs and medical visits. So we know that that there are some of the top diseases in our country are associated with adverse childhood experiences. So cardiac issues, diabetes, depression, asthma, and those are all very costly disorders. And if we're not kind of talking to our families about their adverse childhood experiences, we may be missing the boat on being able to truly help them, and they'll just keep getting treated for their medical issues and or kind of treated in a narrow path for their depression without really getting at the root cause of some of what may be driving what's going on for them.
And I remember there was a letter that Megan had really shared with, you know, our team or a clinical team or just, you know, other providers. There's this letter called A Letter to My Doctor. I think that's the name. I think it's a perfect example of how, you know, those early or just trauma in general, how it really impacts our physical health. If you have time to read it, it basically, you know, outlines this story for this woman or this lady who has really been in the medical system really throughout her life since she was really young. And then she was getting treated for all these different physical, you know, illness, and then she just never really improved, you know, despite all these continuous treatment targeting all these physical difficulties that she was experiencing. It wasn't until much later on where she actually met a doctor who discovered that she really, a lot of the symptoms or behaviors that she was presenting with had more to do with some of the earlier childhood trauma that she had experienced. So that was really, you know, where all these behaviors or difficulties were kind of stemming from. So by really kind of pushing her or redirecting her to mental health treatment or really services to address these trauma, she actually saw significant improvement in her physical health as well. So again, it just really speaks to the importance of, as providers, we really need to, you know, really assess these because I think there's also that cultural component to it too. You know, as we've come to work to learn with a lot of our the population that we work with, sometimes people present very differently. Some people are really they're more vocal about what they have experienced, and then other people really present them more somatically. You know, they might be experiencing more headache, or they might be getting sick more frequently. So again, when we do see those signs, we want to make sure we're kind of asking those questions and really thinking about, you know, what are some of the root causes to that.
Yeah, no, thank you, Yana, for bringing that up. I think the journal article is called Dear Doctor.
Dear Doctor, yeah,
And
there we
yeah,
go.
and it's put out by Kaiser, which, you know, again, really kudos to Kaiser for embracing this movement early on with Dr. Filitti's support and really looking at, how can we do better? I know in that article, as she kind of went through all the different doctor's visits, she was carrying this early trauma, but not bringing it forward. And the comment that always stuck out in my mind was, she said, "You didn't ask. And so I didn't say, I didn't tell you." And it wasn't really that she was trying to not share. It's just, she kind of just, nobody asked. So she kept it to herself. And I think that's significant. When we first started giving these adverse childhood experience surveys to our families, there was some worry about, whether or not we were going to be opening up a can of worms with our families. And, that's just not been my experience. We've been doing it for well over a decade now, and I yet to have a family resist it. I think, sometimes it can make people uncomfortable to be answering some of these questions, but in that supportive environment, that with us there to help and to guide them, hopefully it does feel like a relief, because they are carrying this, and we aren't making these things come to them. We're actually giving them a place to put them that hopefully is helpful. So yeah, so it is a good read. It's a tough read, but if you want to Google it, it's easily accessible. The Dear Doctor article there. Okay, so this is an excerpt from the PEARLS, the Pediatric Adverse Childhood Experience and Related Life Events Screener. So this is the tool that Dr. Nadine Burke-Harris's group launched, that we use to and give to all of our families. It's 10 questions on one page, and then there's a part 2 that, as I said, has just a few more questions related to other kind of toxic stressors that are known, like homelessness and discrimination, poverty, foster care, resource care. So it's a short survey, but it's one that we give all of our families, no matter what age they are, if they are 1 month old or 16 or an adult. If we're working with an adult, we're going to give them a survey, and there's different versions. There's one for kids under 11, and then there's an adolescent version, and then there is an adult version as well. It comes in 17 different languages. You can see here on the corner, the ACEs Aware website, acesaware.org is where you can see the tool. And as I said, it's readily available in lots of different languages. And if you're in California, and depending on your sort of funding parameters, you may qualify for reimbursement by the state as well. So that's, I think, speaks to the support that's out there for bringing these conversations into your office. Something to note is that this tool is an event. It's looking at events. So it's not looking at symptoms. It's not looking at characteristics, but just, did this happen? And as we talked about with that ceiling tile, right? Excuse me. When we talk about that ceiling tile, we don't know if kind of the level of impact on the person. So one event could be really significant, and just because it's not that 4, which we kind of think of that score of 4 as a threshold, it still may be something that we want to pay attention to. And then other times, looking at a higher score and really seeing, well, how is this impacting that person, that individual? So that's, I think, a significant piece of it. The different questions have different levels. There are different kind of categories. So looking at physical abuse, emotional abuse, and sexual abuse. And then again, looking at more kind of environmental stressors, household dysfunction. So I think someone mentioned in the chat, the parent incarceration, mental illness of a family member, substance use, parent separation or divorce, and then intimate partner violence, exposure to domestic violence. All of those are things that we, bring up to the parent. We always have this filled out in the office. This is not a questionnaire that I would recommend sending home, having somebody just sitting with themselves and filling this out. We really want it to be, in a supportive environment with somebody who can talk with them about anything that they're bringing forward and create that sense of safety and comfort. So that's a glance at the tool. It's called the PEARLS, and it is basically the ACE survey embedded into a little bit broader of a questionnaire asking about toxic stress. Then if you, and in our work, sometimes what we'll do is we'll just ask about the event and we won't go further. But other times we're really wanting to look at characteristics. So for example, an ACE score of 1, as I said, may be not really significant to that individual but other times they may have just one event and it's going to show, they're going to be showing a lot of symptoms that are tied to that adverse childhood experience. And so there are a number of tools that are out there, not a ton, especially when we think about really little kids. There are not a lot of tools, but we've hunted them down, and if they're here, we've put them up for you, and we use them. The one that we use the most in our population for birth to 5 is the trauma symptom checklist for young children, the TSCYC. And so that is one that you have to, there's some, you have to order it, but it is available to us, and it is a helpful tool for understanding, again, looking at different symptoms and how they might then translate to potential diagnoses such as post-traumatic stress disorder or other, mood disorder, other issues tied to the trauma. And then here's just a list of other measures as well. Something to note, thinking about these questionnaires, of course, we don't have the child fill them out when they're really little. They can't read. Most of our kids can't read and write. So we do talk to the caregiver about being the voice for the child and really having them help us to understand, an event that they're aware of that the child experienced. And sometimes the caregiver may not know. So an example there would be a child who was removed from their home and now they're in a resource placement, and that resource provider doesn't know the child's history. So they may not have all of the information to really get their Pearl score as accurately as if somebody else who had been with the child earlier on might do. So sometimes it is worth re-asking those questions depending on the level of connection and the length of time that the person has known the child. But we ask them to bring this forward, and then it is our way of hopefully communicating the need for services. So again, thinking about the babies who aren't eating and sleeping and pooping the way that they should, if we say, well, they have an ACE score of 4, and we know in the adult literature that this correlates to really poor outcomes, and we're seeing some symptoms, they're not eating right, then this is, I think, enough of a rationale for us to be bringing things forward to having some intervention. And so again, not waiting until they're older and experiencing things or verbalizing things in a very clear way, but we help that child by connecting the dots with the tools that are available to us and just recognizing what really is not expected to be happening at that developmental level. Okay, so in our work, we talk a lot about taking a developmental approach to understanding a child. So when I'm working with a 4-year-old, I don't want to just know their age. I want to know their developmental level. But I also want to take a trauma-informed approach as well. So I don't want to just be thinking about behavior. I want to be thinking about, well, what could be sort of driving this behavior? Is there any kind of trauma that has happened in this child's life? And have I asked that question to everybody who might have information about their history, about things that have gone on? Have I created an environment that is going to invite that kind of conversation? Do I understand, as Yana talked about when she kind of first introduced this, that the connection between trauma and behavior and how a person presents? So making sure we're aware of that, integrating trauma, an understanding of trauma into a child's treatment plan. That's going to be really important. And as we're making recommendations, that we're thinking about their traumatic experience, and we're not just recommending services that are going to be addressing behavior, but it's going to be a trauma-informed approach, for example. And then also, looking at our role. So an example there is, as providers working with individuals who've experienced trauma, how are we doing with creating a safe environment? Examples could be, sometimes we'll have students come and observe our setting. Well, what's that like for the child who's had a lot of different people who are not familiar to them come into a setting where they are? How is this impacting them? If I have a resource parent and a birth mother, for example, in a session with me, what's that like for the child? Here are these two people that are really important to them, and they're not usually together, but they're in my session. How's that impacting the child? So really taking into consideration some of those features. For those of you who do more treatment services, I think the concept of time is super important. If you're late to a session, how might that be impacting a child who's really had maybe an unpredictable kind of world? And if you're late, are you really creating that sense of security? How are you, talking about that? Are you saying, gosh, I'm sorry I was late, and owning that? Or are you just dismissing it as, well, that happens? Are we really helping and bringing that into our sessions therapeutically? Even going on vacation, we're all allowed to go on vacation, but how are we doing with preparing children who've experienced traumatic situations? Again, that unpredictable environment. Are we letting them know what's happening, and that the plan is I'm going to come back, making sure that they, that you help fill that in for them, and then just talking sensitively and creating that environment for the family to be able to really normalize conversation around this and to create understanding. One of our big goals in working with young children is we want to do anything we can to not have a child lose a placement, whether it's a school placement or a home placement. And so the more we can help bring the conversation around understanding the child, they're not misbehaving, they're communicating with their bodies that they've been very stressed out for a really long time, potentially. And so helping them understand through the use of diagnoses and through conversation and education around trauma and the impact on a person, that hopefully that's going to help create more understanding, create more tolerance, and create a situation where potentially a child wouldn't have to leave a home or a school setting, because there'd be more understanding and more of an appropriate response to what's going on with them.
All right, so we talked a lot about kind of like, just trauma in general, the different types of trauma, and then the impact, trauma has. So how is early childhood trauma unique? Well, as children grow up, there's a lot of really profound sensory impact that these trauma has. So when they're in that early age, children are less able to anticipate danger or really know like how to keep themselves safe, because they don't have the coping skills to keep themselves safe, because they don't really have that physical capability to keep themselves safe. And also, they're not really able to express themselves in words. That it's not just with the kids with this age group in general, but then also a lot of the kids that we work with, they have speech delay, where they have developmental delay. So they're just not really able to use their language to communicate with us how they're feeling, whether they're feeling scared or they're stressed out or they're feeling really hopeless or helpless. There's just no way for us to know that verbally. So I think as providers or as clinicians, we really need to look at things more comprehensively. What are some of the behaviors or symptoms that they're presenting? Like Megan was saying, if they're not really able to tell us verbally, what are some of the behaviors that they're trying to show us through their bodies or through other ways? And also, what's really interesting is that early childhood trauma has been associated with reduced size of the brain cortex. So as we all know, the brain cortex is really essential for a lot of our executive functioning skills. So impulse control, being able to sustain our attention to complete a task, to learn different things, or visual spatial skills. And then as we will talk just a little bit more, later on, having experienced those early childhood events really have a significant impact on their neurobehavioral pathways. It changes really how they perceive their environment, how they perceive specific events that had happened in their environment. And also, at an early age, children really depend exclusively on the parents or really caregivers in their environment for survival and for protection, as we talked about, both physically and emotionally. And then also, research has found that there are critical or these sensitive periods as a child grows up, where if they miss these periods of time where they can learn different essential skills are really critical for their development, it's not very likely that they will gain those skills back. So what they're saying is that once we miss those time, it's really hard to make up those skills that they could only learn during that critical developmental time. So again, if a trauma happens during that time, it would likely have a much bigger impact if the trauma had happened later on. So again, just speaks to what Megan talked about. Sometimes the timing or really the type of trauma is really, unique. So Bruce Perry, who is a really well-known psychiatrist and who has done a lot of really tremendous work with children that have gone through a lot of trauma. Lately or recently, or more recently, he had written a book called What Happened to You? It's a book talking about trauma and really how people perceive those trauma and then how it really impacts their relationship with their environment, the people in their environment, and then things like that. So in his book, he talked about really the critical, really the importance of the first 2 months of a child's life. So he writes in his book that the basic finding is that the experience of the first 2 months of a child's life have a disproportionately important impact on their long-term health and development. And this really has to do with the really rapid growth the brain has early in our life, and really the organization of those very, very important core regulatory networks. So kind of like the brain pathway, the neurological pathways that we were talking about. So if in the first 2 months of a child's life, he or she experienced really, really high diversity. So this is kind of the gray scale that we're looking at on the left side with very minimal relational buffering. So that's kind of the relational buffering is the blue scale that we're looking at on the right side. So if the child has experienced really high diversity with minimal relational buffering, but then was put into a healthy environment for the next 12 years, their outcomes are still worse than the outcomes of children who had low adversity and healthy relational connection in the first 2 months, but then spend the next 12 years with high adversity. So just let that sink in for a moment. The child who only has 2 months of really, really bad experiences does worse than a child with almost 12 years of bad experiences, all because of the timing of that experience. It sounds really, really discouraging, right? But I think this is a perfect example of why we need these trauma-informed and developmentally informed and really trauma-aware system. Again, it's never too early to start. We want to make sure that we're capturing these symptoms that, we're capturing these kids from a very, very young age and then providing them that ongoing support through our trauma-aware system. Okay.
I was just to add too, I mean, when I first saw this from Bruce Perry, and he is a really well-known person, very, very expert in his field here. And that just blew me away. The first 2 months are the most important. I honestly couldn't believe it at first. And yet I think it, as Yanan said, really speaks to how important it is for us to be asking those questions early on. And I think so often we hear, well, the child, was so little that we think of that as a protective factor. And yet we know that this is, we need to be paying attention to this from birth, if not before, and how important that is to be looking at those early moments and that relationship and what an important piece that is. And what can we as professionals do to really help foster that relationship? As Yanan said, we don't just work with the child, we work with the child in the context of the family system there. And so it's really important that we're working with not just the child, but with the whole system, the family, and really looking at that relational piece.
And then this is really kind of like a chapter from Dr. Bruce Perry's book called What Happened to You. So if you're interested in more information, he talks a lot more about this in that book. So definitely feel free to check it out. And also if you are interested in reading just more case studies, recently I've read one of his other book called The Boy Who Was Raised as a Dog. So he talked a lot about kind of different case examples of children that he had worked with very earlier on when he first started his work with children that had gone through a lot of trauma. So if you're interested, it also has a lot of really just great case examples where he talks about their current presentation or, their presentation when he was working with them, and also some of their early childhood trauma that those individuals had gone through. So definitely feel free to check that out.
And I see Rose has a question about where it came from, or I can put a link in the chat here for you guys. Just do that real quick.
Okay, perfect. And then so while Megan does that, let's look at some of the symptoms and behaviors that we commonly see with children that have experienced a lot of trauma. So, one of the things that we talked about with the pearls is that it really just talks about events. It doesn't necessarily look at symptoms or behaviors. And then so, when we are seeing a child that has gone through a lot of those aversive events, typically some of the behaviors or symptoms that we see including kind of behavior or skills regression. They used to know how to do something and then all of a sudden they just stop doing it, or they're becoming a little bit more dependent. Even though they know how to do something, they want your help with it. Or a lot of them resort to some of that immature behavior. So some ducking, being really scared of the dark, or really wanting to be cuddled, wanting to be treated like a baby. And then for some of those, we do see them kind of engaging in more like acting out or like aggressive behavior. They tend to react really quickly to things in their environment, often disproportionately. So, even though for you or for us, it might not be that big of a deal. Say things like they're having a hard time pulling their socks up in the morning. But then because of that, they're having a really extreme reaction to an event like that. Or with some of them, we see them becoming a little bit more withdrawn. So, not interested in socializing with other kids anymore, not interested in socializing with the other adults anymore, just becoming a little bit more clingy, a little bit more kind of crying, more temper tantrum. And then for some of them, they're presenting with more of that symptom or somatic behaviors that we were talking about earlier, where they're losing their appetite, they're not eating as much, or they're having a really hard time sleeping at night, or they're having a hard time staying asleep at night. They're waking up more often, they're having more night terrors, nightmares. So those are some of the physical kind of symptoms that we often see. And then talking about the effects of trauma exposure, one of the things that we had mentioned earlier on was that when a child has gone through these early childhood traumatic experiences, it really creates disruption in their biological or their regulatory rhythms. So it changes kind of how their brain perceives things, and then it changes the way that the child responds to different events in their environment. Because it does provide that fundamental change to the structure and then the function of their very much developing brain. And then so with a lot of these kids, we see problems with movement and then sensation. They might be more sensitive to different sensory processing behaviors, like they're becoming more sensitive to noises, or they're becoming more sensitive to touch, to smell, to all these different things. And then we talked about the somatic system. So usually with some of these kids, we see more increased medical problems. They're getting sick more often. They stay sick longer once they get sick. And then it also has a lot of impact or effects on their or on their behavior, or emotional regulation. So with a lot of the kids that we work with, we see them having really a hard time regulating their emotions when things don't really go their way. Kind of like the sock example that we were talking about earlier. They're having really disproportional reaction to things in their environment, and then they have a really hard time sustaining their attention, and then their arousal level is always really high. Because if you think about it, with a lot of these kids that have gone through those trauma, they're constantly in that fight or flight response, right? When your arousal level is constantly at a very high, your baseline kind of changes, right? So before, the trauma, your baseline might be somewhere here at the bottom because you're perceiving your environment as a very safe place. But then after that, your baseline rises, right? It gets to the point where you feel like, okay, am I safe? I'm not really sure. You're constantly in that very alert status. So again, it really changes how your body regulates itself. And also, as Megan mentioned earlier, it really creates barriers for kids to form secure attachment because their basic trust and then their safety has been threatened. They're not really sure if they're in a safe environment. Like I think a lot of you have mentioned food insecurity being one of the traumatic experience that a lot of the kids have experienced. So when you constantly don't know when you're gonna eat next, we see a lot of kids who are just like stuffing themselves whenever they have food. So again, think about the behavior and then think about, is this from the trauma or how is the trauma impacting their food just relationship in general? And also from a developmental perspective, we talked about how, with a lot of our kids, we see a regression in their skills. So a lot of that previously acquired skills get lost, where all of a sudden they stop progressing, developmentally. So they were doing really well, and then they stop doing things that they know how to do, and then they just don't seem to be learning new things. So when that happens, we really want to really make sure that we're looking at things from a more comprehensive perspective and then really providing them not just mental health support, but developmental support as well.
And Yanan, as you're advancing the slides, I just want to say I added the name of the book title in there, and just another plug in case those of you are Oprah Winfrey fans. The book is actually a joint effort with him and Oprah, and she does a pretty powerful account of her own life there in the book as well. So just wanted to add that.
Perfect. And then just really briefly, because I just did a time check. So some of the additional effects of trauma, we talked about a lot of these already. When you don't have a really, like what Megan was saying, a predictable pattern of what to expect, a lot of our kids become a little bit more avoidant, or they're not really able to perceive those social cues, when they're in that social context really appropriately. So we see a lot of them having a hard time interacting with their peers, or really just not really understanding the nature of those social relationships. And then we also see them having a hard time with impulse control. And then a lot of them tend to have more destructive or self-injurious behavior or aggression towards other people. And then in terms of their cognition, again, kind of in relates to the behavioral control, they have a harder time focusing their attention, or really kind of having challenges with completing tasks or really learning new things. We just talked about how those early childhood trauma has an impact on, or is related to reduced cortex. So, those brain cortex are really important for executive functioning, which is one of the reasons why we're seeing a lot of these kids having a hard time planning, anticipating future events. Again, some of that skill having more to do with that long-term planning skills.
Now I get the cute job. So this is a little video we want to play for you, and I think it's a nice way of launching into our discussion about the overlap in symptoms between children who've had traumatic experiences, and children where there's a concern about a different developmental or behavioral disorder. As we think about some things that children may present with, I think again, this just highlights how important it is to understand the child's history. So I'll just warn you that this is a little bit tricky or a little bit hard to watch, but it's called the still face experiment. If you haven't seen it, it's you can look on YouTube it does a really nice job of just capturing the importance of the parent-child relationship, the caregiver-child relationship.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
Are you my good girl? Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, come on, why aren't we doing this? Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Isn't it great to get to see them coming back to playing? I'm so much more, I'm just relieved when we get to that part. It is hard to watch, but I think important when we think about different diagnoses, a diagnosis that I'm often confronted with is autism spectrum. And some of the things we know there is that's a diagnosis that impacts social behavior quite a bit. And so you saw the child being such a social being, right? Reaching out for the mom, making good eye contact. I know it's a beautiful video, just that connection and how critical that was. And then when the parent withdrew that attention, how we saw the withdrawal and the lack of eye contact. And you can see that how easily that, if you hadn't had that full story and you just had a little glimpse of that second part of the video, you might be thinking, well, does this child have autism? Things like that. So I just think this is a pretty powerful video and a good place to segue into a quick overview of our different childhood disorders, developmental disorders. And we do want to let you know that we're going to be doing another talk through Caltrin in February that's going to highlight even more in depth on some of these disorders that Yanan's going to go over with you.
Yeah, so we're just going to go over these really briefly because we do want to save time at the end for questions. So autism spectrum disorder being one of the really commonly, developmental disorder that I think we've come to interact with. And really some of the core characteristics or features that we see include, social difficulties, not understanding the nature of social relationships, not being able to pick up on social cues, and then delay in their verbal and nonverbal communications. And really a lot of these kids present with significant repetitive behavior or behavior rigidity, like wanting to do things their own way only and not being really tolerating when it comes to changes or transitions between activities. And then the other commonly seen developmental disorder is ADHD. So that's where we see a persistent pattern of inattention and or hyperactivity or impulsivity that really becomes interfering with the child's daily functioning or their just development in general. And then, with these behaviors, we want to see them happening across the setting. And then we really want to see that these symptoms become, again, really impacting of their daily living activities. And then that's when we, when parents say, well, is it because he's 5 or is it the ADHD? So again, thinking about what is developmentally appropriate and then when we should become a little bit more concerned from a clinical perspective. And then fetal alcohol spectrum disorder being another one. So I think this is where, as clinicians, it's a little bit more challenging for us sometimes to have the conversation, with the mother of, have you had any exposure to substance, during your pregnancy? And I think one of the common difficulties that we run into is that when we just ask the broad question of like, have you had any exposure or access to substance, people think about the very difficult or significant ones like meth or heroin or cocaine. They don't really think about alcohol because alcohol is such a socially acceptable substance, but it turns out it's one of the really the most impacting ones when it comes to a child's development. And then so far research has shown that there's no predictable correlation between the amount of alcohol exposure and really the impact it has on the child's development. So really, there's no safe time during a pregnancy to drink, there's no safe amount, and then there's no safe type of alcohol. Beer still counts as alcohol, wine counts as alcohol. So again, when you do feel like, or when you do suspect that there is a potential that a child or possibility that a child was exposed to alcohol, just kind of keep in mind to ask those very specific questions to make sure that you rule out all of those possibilities. And then just with all the other developmental disorders, like autism that we talked about, fetal alcohol spectrum disorder is also a spectrum. So kids with this disorder present very differently. Some of them have physical features, some of them don't. Some of them only really present more of that neurobehavioral profile where they're having, a lot of difficulties with their emotional regulation, with their impulse control. So I remember when I first started working with kids that have prenatal exposure to alcohol, Megan put it really nicely. When you look at their profile picture, these kids are kind of ADHD plus, where they have all of the typical features or characteristics that you will see with kids with ADHD, but then they also often have a lot of difficulties with emotional regulation or really their social awareness. Again, if you want to learn more about these, please come to our talk in February because we are going into much, much more details about that. And then, so kind of going back to what Megan was saying, some of the earlier signs, in babies, when they're not eating, when they're not pooping, when they're not really, responding to your voice, when they're becoming a little bit more withdrawn, when they're not really expressing a lot of or a range of emotions, those are some of the early signs that we want to look for potential depression in, babies or infants or, kids in a really, really young age.
Yeah, and just a quick example there, Yana, and if a parent comes in and says, my baby's so good, he never cries. It's like, babies cry. That's how they communicate. So we want to pay attention to that.
Absolutely. Again, kind of thinking about what is developmentally appropriate for a child. What are some of the behaviors that they should be presenting at this age, and are they doing it? Or, it's normal for a child to cry, right? Especially when we see our 2-year-olds, parents will often say, oh, they're just being a typical 2-year-old. They don't like hearing no. So that might be developmentally appropriate. But if you are working with a child who, these sort of like behaviors or tantrums happen more intensively to the point where they're actually injuring themselves, or these tantrum behaviors happen multiple times throughout the day, then I think that's when we want to become a little bit more aware of, we might need to do just kind of another thorough assessment to see if there's anything else going on. again, some of the common or early signs that we want to assess for anxiety. Are they constantly worrying about something? Are they having disproportional fear to kind of what seems normal events? And then do they have to do things in the right order where they feel like something might happen? And then are they constantly asking for reassurance, even though it's not really necessary? So again, if we, after talking about all these behaviors, there are a lot of overlaps with these. So when we look at, how a child might respond or how they might present after they have gone through traumatic experiences, and then how a child might present when they have autism or ADHD, there is a lot of overlaps. And then sometimes it makes it makes it really hard for clinicians to get to a diagnostic clarification. And I think that's when we really need to look at things, from that whole family perspective. We're not just looking at the child, we're looking at their environment, their history, and then really conceptualize things from a broader perspective. And then I think the other message is that, if you are not getting the diagnostic clarification that you need, that's when we want to bring that trauma-informed care, right? That ongoing assessment, make sure that we're addressing those difficulties first, instead of saying, well, I don't know what it is, so I can't really do anything about it. So I think, when we do not have the clarification we want, that's more of a reason for us to start treatment and then see how they're responding and then provide them with that ongoing assessment.
So at the beginning of our talk, Yanan introduced you to Jimmy, and we got to look backwards at what could we have done if he was, if we met him when he was 10 months old. Well, here we want to introduce you to Nathan, and this photo is not really Nathan. It's actually my son who's now in college, but wanted to just paint a picture of this little guy that I saw. When I first saw him, he was 2 years old, and I saw him, he had been removed from his parent. And I saw him in a detention center where children go when there's a concern about child abuse. And I evaluated him, and actually his mom was there visiting, so I got to hear a little bit about his history. She was diagnosed with ADHD as an adult, had a substance abuse history. He presented as incredibly dysregulated, but bright. And you can see, some of his scores here were in the average range when I first saw him. And actually, I'm sorry, he was 3. He was almost, I think when I saw him, he was, the first time I actually saw him 3 times. So these are just his IQ scores, but this was the second time I saw him, but consistently showing really intact cognitive skills. And then we got to see him but a lot of diagnostic kind of confusion. So he was, there was a question of, does he have autism? Does he have ADHD? What's going on? Oppositional defiant disorder was put out there, and just lots of different opinions. And what we did really well with this case was we allowed for assessment over time. And just really carefully looking at his history and not rushing to deciding what a diagnosis was. As you can see, by the time I saw him for a 3rd time at age 5, his scores actually had gotten even higher a little bit. That doesn't always happen, but they certainly didn't get lower, and yet he'd been through so much. What was happening at 5 was he was actually in a stable placement. And someone just put a little heart there in the chat. And yeah, I think that is a really good sign. And if we go to the next slide, I can also show you some other changes in how he presented. Oops, I'm sorry, Yanan, I was looking at there we go. But he, so when I first saw him, there was one of the tools we looked at really said that he was showing some signs of autism. Then I saw him again, and he showed even more clearer signs. And we were wondering really about that diagnosis, but there's just something that told me, let's give it a provisional, which means let's not rubber stamp this as for sure. And then when I saw him again at 5, he really didn't meet criteria for autism. And it wasn't that it went away, it's just that it became clearer over time. And I think for some of our kids, that's really what it takes, is assessment over time, careful history taking, collaboration, and just really good work with a lot of different people, and making sure we're understanding the context with which that child brings in. A lot of his presentation had to do with his different kind of levels of trauma that he was experiencing throughout those first 5 years. So, love isn't all a child needs. They certainly need stability. We know that this story could have ended differently. He could have had a diagnosis that was more definitive and reaching clinical levels. But I think what was important about this particular story is that we really took our time and didn't rush to a diagnosis, and we looked very comprehensively at what was going on. Just a happy one there.
Absolutely. So, we talked a lot about trauma and then really the impact, it has on children. But with young children, there's also resiliency. And then it is something that they build along the way. It's not something that they were born with. And then when we look at these protective factors in their environment, in their home, there are some things that we don't always think about. Like, are they in school? Maybe are they involved in church? Are they involved in the community at all? So, I definitely encourage you to start thinking about all these different resources, just things that you can involve them in to really build up that stability and then that consistency in that environment that a lot of them just don't really have. And then kind of the story that Megan had just talked about, sometimes we're really surprised to see what that consistency could do for a child. And it's definitely something that we want to kind of build into their routine and then their environment so that they can really focus on developing those skills that they need to continue to grow and make progress. And with that being said, we'd like to end on a very positive note. Megan, do you want to introduce this while I pull up?
I get all the cute kid.
Yeah.
So as Yanan was saying, with the protective factors and just our role as professionals with our families is, what can we do to help support a family? And I think this video, if you haven't seen it, it's kind of went viral all over YouTube, but it's a great example of that, caregiver parent-child relationship done well. This dad does an amazing job of responding to his child. So we're just going to let you watch it. And like Yanan said, we're going to end you with a smile on your face. I guarantee it. I challenge you not to smile when you watch this.
Right. Yes. Okay. Did you understand it though? No. Okay. All right. Huh? Oh no, not this one. This is the grand finale of this. Yeah, that's the last one. That's what I was wondering. I don't know what they're gonna do next season because they did some stuff this time. Exactly what I was thinking. Oh yeah. Right. Don't bring that again. You know what I'm saying? Don't do the same stuff. You know what I'm saying? Yeah, I was thinking that. Yeah. Yeah. Like go somewhere else with that, but don't bring it here. You know what I'm saying? Yeah.
I'll pause right here.
Yeah.
Awesome.
The timing with that data is just great. And the child's response is just priceless.
Okay. There we go.
So I know we don't have much time. We're happy to stay over if needed for any questions, or you can certainly put them in the chat and we can do our best to get to them. I know we have a plug at the end as well for what's next.
As people are dropping questions into the chat, I just want to make a reminder for anyone that is unable to stay that the note-taking slides that were dropped at the beginning of the session, the recording for today, all of that is available in a 2-day follow-up email. It's the Caltrin way. If you've been here before, we typically send an email follow-up. I'll also remind you of something very important. This course, if you were here for the live full session, this does not apply if you're watching the replay. This course meets the qualifications for 1.5 hours of continuing education credit, that's CEUs, for LMFTs, LCSWs, LPCCs, and or LEPs, as required by the California Board of Behavioral Services. That can be accessed. So if you're interested in that, of course, it comes to you at no cost. You can respond in the survey that we just dropped into the chat. Click that survey. It's a very brief survey to ask you about your experience today. They all come with the certificate of attendance. I should say certificate of, attendance. And then in that survey, you'll see information about the CEUs if you're interested. So please feel free to access that survey now. And that will bring us to time, but it sounds like if there are any questions, our presenters have offered to stay over for a few moments as well.